thought our friends from South Asia would add a great value to this endeavor of how countries in the region are coping up with COVID-19 crisis. As you know, right from March 25th onwards, continuously RIS has been coming out with a lot of literature, a lot of seminars, largely on economic and trade impact of COVID-19, industrial production, financial architecture, supply of money and credit volatility, the crisis of MSMEs, and many issues we have covered, including the impact of technology. But today we have taken an issue which we have never taken before, but I think is assuming great importance in the larger canvas of health management. Of course, at RIS, we have a very active program on health, again, from the perspective of trade and economic development. So as a part of that rubric, Professor T.C. James and Dr. Namrata Pathak have been leading that work program. And I'm very thankful to both of them for supporting and taking it forward. But today we have also partnered our today's endeavor with Sangath. And Sangath is an important initiative, and I must congratulate Dr. Anant Kahan for having initiated this partnership with RIS. Sangath, as Anant would inform later, is a non-government organization, not-for-profit organization, which has been sort of trying to commit itself for improving health across the communities, empowering them and supporting their various initiatives and programs of the government for strengthening the larger community health initiatives. RIS has also been focusing on sustainable development goals, and from that perspective, SDG 3 is of great significance, where Professor T.C. James has been leading our work program. And we are also working very closely with Ayush, which is sort of bringing in the wholeness to our approach on health sector. In fact, at a recently held BRICS meeting, RIS had proposed a wellness index, and those of you who are interested, we would be very happy to share our report, where we have suggested to have an alternative after the Human Development Index of Wellness Index. And if Wellness Index comes in, this dimension of holistic approach to our health crisis and health management comes in. With some conservative estimates, it's very clear that post-pandemic mental health impact on economies is going to be somewhere close to 1 trillion economy. And as more and more studies are coming out, the dimensions are unfolding. And I think it requires greater efforts, not only by the health professionals, but by several of us who are engaged with society and are seeing the impact in terms of how industry is responding, how economies are responding, and how developing countries can pool their resources, expertise together for a comprehensive and very cogent and coherent response to this crisis. Friends, today we are extremely privileged to have two very bright minds in this area. Professor Srinath Reddy requires no introduction in such platforms. He has been a recipient of Padma Bhushan and has been a key advisor on health sector issues. The Public Health Foundation, the PHFI that he has established, is one of the key actors, not only in India, but for whole of South Asia, I would say, where they are bridging this huge gap between what the practitioners face and what policymakers consider. And it's very interesting to see the way he has shaped not only national policies and international policies with WHO, but also at the subnational level with several states with which he has been working very closely, be that Andhra Pradesh, his own state, or Odisha and Punjab, Haryana, Delhi government, where he is playing an extremely important role, and PHFI has done remarkable work in bridging the gap not only in South Asia, but also with Africa. And his positions in WHO, he has leveraged very well in terms of articulating that. 2 years back, we had a great privilege of working with him on food and nutritional dimension of food and its connect with health. So he is also trying to revisit this question in a major way. Fortunately, during the lockdown period and as the pandemic was engulfing many countries, RIS and PHFI worked together on RIS platform of Global Development Center to organize capacity building programs for several African countries, and several countries participated there. So welcome, Dr. Reddy. We are very keenly looking forward for your address today. We are also privileged, friends, to have Professor Vikram Patel, who is a professor at the Harvard Medical School. He has been one of the commentators who could connect not only with the academic work that he has been doing, but with several organizations across the spectrum, and has been very well connected with the World Health Organizations. He has been a co-founder of Sangath, and has been linked with several international institutions across the world, be that in UK or US or in other parts of the world. He was listed in Times Magazine as most influential top 100 persons in 2015. So congratulations, Professor Patel, and welcome to this discussion today. With friends, we have a very packed agenda today, so I would just request, without further ado, Professor Srinath Reddy for his comments, and after that, Dr. Vikram Patel. So, Professor Srinath Reddy, you have the floor, sir. Thank you.
Thank you very much, Professor Chaturvedi. It is a pleasure to be always part of the RIS platform, and we've had the privilege of working with you very closely. And Sangath also has been a close associate for several years, particularly through Dr. Vikram Patel's association. And I think this particular platform brings in many friends together, not only from India, but elsewhere too, to consider one of the biggest public health challenges that we will have for the 21st century, which has been there, but has been neglected in the past. Well, in terms of mental health, it's very clear that though the context of this particular webinar is COVID-19 and its impact on mental health, the whole area of mental health is a long-standing issue, and the challenges have been there for quite some time and very inadequately addressed. We do know that mental health disorders contribute to a very high component of the global burden of disease in terms of disability, and even suicides add particularly to the deaths as well in very young ages. We also know that there are huge economic losses as a result of mental health disorders because of loss of productivity, the caretaker time being taken up, and multiple other reasons. And we do recognize that productivity is also greatly reduced, and therefore the nation also tends to lose in terms of its economic growth. However, despite all this, there's been many years of neglect, and which has only recently begun to be redressed. The health system had turned a blind eye to mental health, whether it was Millennium Development Goals or even other major global declarations. And sections of society viewed mental health disorders with derision and heaped stigma. Family members hid it, and individuals did not seek care and suffered in silence and sorrow. However, in recent years, we have seen mental health beginning to get belated attention, long overdue. And we have seen it initially positioned in the political declaration on non-communicable diseases in 2011. And the Indian delegation did have a big role in ensuring that it got inserted along with 4 other NCDs, at least in the declaration. But in terms of its very clear mention as a global health priority, it is featured in the Sustainable Development Goals of 2015. And then in our own National Health Policy of 2017, mental health has been finally accorded a place of prime importance. But then when this was happening, and finally we were beginning to get our act together to approach mental health with the seriousness it demands, even though the preparations were still inadequate, COVID hijacked the entire health system. And we see that many other priorities of health have now been sidelined. And we see that mental health is not getting the kind of attention it really requires, despite the fact that COVID itself contributes substantially to mental health disorders now. We know that the overall determinants include social determinants like poverty and other inequalities. Though they may not be immediately redressed, they have been accentuated by COVID-19 situation. Among the various stressors which actually contribute to mental health and are particularly evident during the COVID-19 period are social isolation, job loss, income loss because of wage cuts, uncertainty about the future, about education, about employment, disruption of social connectivity from family, friends, colleagues at work, and schools or colleges, increased alcoholism, dramatic rise in domestic violence, fear, stigma, discrimination directed against people suspected as having COVID or their family members, or even healthcare providers who are providing much needed service to people who are suffering with COVID or being investigated for it. Misinformation has been fueling anxiety and fear, and we are now seeing that also is affecting the mental health of many people who are unsure as to what is the right information, to whether to believe the kind of rumors that are floating around or get their mental stability greatly unsettled. Then you have digital addiction coming up now because people are confined to home. There is also online teaching, but more than teaching, people are now, instead of socializing with friends and family, are forced now to seek electronic media for their entertainment. And that again is becoming a problem which calls for digital detoxification. Then other addictions are increasing, even tobacco. People who have given up smoking now under these stressful conditions are going back to taking up tobacco, and this has been documented in many countries now. But coming to the health system itself, services have been interrupted, and even the services that were available, whether at an institutional level or at the community level in particular, are no longer dependable because of the COVID-19 taking the primacy of attention. Supply chain disruptions have also taken place, and we see that in terms of essential needs, whether it is food supplies or whether it is even in terms of medical supplies. And these supply chain disruptions also add to a lot of anxiety and angst. And all of these are certainly not conducive to good mental health. So what we do require now is to provide both a very robust health system response as well as a social system response. It can't be just on the basis of the health system. The health is absolutely critical, and the health system must rise to the occasion. But the social system also has to be supportive. We may not be able to alter all the conditions at once, but whatever we can do to provide enough relief and redressal must be certainly addressed. So we need to build resilience at the level of the society, community, family, and at the level of the individuals themselves. And what we need are systems that can provide strength and support all around to people who are likely to be in distress or are likely to be unsettled. And we need, as I said, resilient social systems which can provide that kind of social support to people who need it, and certainly try and avoid or erase stigma and discrimination, which is a major challenge. At the same time, we require resilient health systems which can provide efficient, equitable, and empathetic care. And particularly, the role of frontline health workers is absolutely important. Right now, many of the frontline health workers are battling COVID. They may not have enough time to attend to some of these issues. But if we can build community networks involving the frontline health workers, but also get in extensive citizen participation, what I would call people-partnered public health, then we can actually mobilize the community resources not only to aid in the health effort, but also to provide the kind of health and social support services that are required for mental health, which really do not require very fancy technologies. So the importance of frontline health workers is something Professor Vikram Patel has very clearly outlined in his own work, but that needs to be reiterated. The role of other community participants like self-help groups, other opinion makers, and local community leaders, all of them is going to be absolutely important. And since we are in the midst of in this effort with the collaboration of RIS, which spells out research, we must also talk about research. There is a definite need for implementation and operational research during this phase to see how best we can mobilize all our resources, whether it is the availability of certain degree of telecommunication and IT technologies for providing counseling and care, or particularly in terms of how we can actually utilize whatever resources are there in the frontline health workers and the citizenry to provide the kind of care that's required. So that kind of an implementation research is also absolutely important, and I believe that is an agenda that can be taken up. But obviously, a global threat like COVID-19 calls for a global trust to counter it. And that is why solidarity among countries and sharing of knowledge and expertise is absolutely important. And having this South Asia Forum convened under the auspices of the RIS is absolutely important and timely. And I'm sure that this forum will continue to bring in a lot of experience and expertise and generate a lot of new ideas and new initiatives to address a challenge which is going to remain with us. Of course, this particular initiative is not going to wilt away after COVID-19 fades away. This is something that we must utilize to build a much more robust response afterwards, where even when COVID goes away, as they say, building back better in every way, our health systems as well as social systems, so that mental health no longer remains such a major unaddressed challenge. Thank you very much.
Thank you. Thanks a lot, Professor Srinath Reddy, for capturing in a very insightful manner the various facets of this major challenge that societies after societies are grappling with. And I think, given the limited public budget in this area, you very rightly emphasized on community participation and the role that frontline health workers may play. I think you have also very rightly emphasized on how the networks among the southern countries, as part of the South-South cooperation among the developing countries, may strengthen and explore further the areas where the communities and particularly the self-help groups that you alluded to, but also the think tanks, the research institutions, those who are working closely with the government may play an important role. Now, I have great pleasure in inviting Professor Vikram Patel for his keynote address. Professor Patel, you have the floor. I don't see the mute sign on your machine, but we are not able to hear you, Professor Patel.
Any better?
We are not able to hear you, Professor Patel. Yeah, it's better now.
Okay, all right. So can I share my screen?
Yeah, please go ahead.
No, I think you'll have to let me. You'll have to give me
enable
my WebEx.
Yes, we are doing that.
So first of all, while you're letting me do that, I wanted to just thank you, and it's a real pleasure to be actually speaking after Professor Reddy, who I have great respect for and who has mentored me a great deal during my work. I am actually going to take on from exactly where he has left off, really talking about the role of frontline workers, and that's really the substance of what I want to focus on in my 10 minutes. Really, what is the learnings that we have about the use of frontline workers and what could be of great value to the whole region. So I want to just start by reminding ourselves that Professor Reddy has spoken a great deal about the impact of COVID-19 on population mental health, but the mental health crisis in India was clearly already very grave even before COVID-19. In the 2016 government's National Mental Health Survey, you can see that whether it was mood and anxiety and trauma-related disorders that you call common mental disorders, or the psychosis that we call severe mental disorders, um, only about 15% or so of individuals in the country who had a clinically significant condition at the time of the survey had actually sought or received any form of care for their problem. And it isn't just the question of receiving care, but also the questions about the quality of care. This is a very recently published data from the World Mental Health Surveys that included India that shows that only about 6% of people with depression, which is of course the most common mental health condition, only 6% of people had actually received quality care, which means care that was in line with the evidence about what are effective interventions to enable people to recover from a particular mental health condition. Now, we often think of supply side barriers as the most important ones in addressing all the different crises of access to good quality care in India, not enough skilled human resources. But also, we should remember very importantly, in the case of mental health, there are also demand side barriers. Indeed, this was also true for many other health conditions, but especially true for demand in the mental health sector because of stigma. And I think it's important to locate and understand the nature of the stigma, which is that for the vast majority of people in South Asia, the word mental health is typically seen as being equivalent to the Hindi word is pagal. It's the person who is very seriously ill and is often behaving in a manner that is irrational. And so the vast majority of mental health problems that do not, in fact, demonstrate behavioral changes are not seen as health problems, leave aside mental health problems. And so there are big demand side issues that we should remember because, of course, across South Asia, the government's response to mental health problems has been identical to any other health problem, very biomedically focused, very focused on doctors, diagnoses, and drugs. And this 3D model is also a major barrier to improving the access to quality care. Now, this is not unique to India. About 10 years ago, the NIH released the Grand Challenges in Global Mental Health, which was really a research priority setting exercise. I co-chair this initiative. And what was interesting is that the question that was put forward to the world's global mental health practitioners is that what would be the leading research questions that, if addressed, could impact on reducing the global burden of suffering due to mental health problems. And perhaps unsurprisingly, the leading questions were the ones that Professor Reddy alluded to. It wasn't about discovering a new gene or a new molecule or a new product, but it was actually about doing better with the knowledge we already have. It was really about implementation science to deliver interventions that we already knew worked in real world settings. Over the last decade, there has been an enormous body of science that has been generated from around the world, which has clearly shown that we can now deliver clinical and preventative interventions in any resource setting. It did not make any difference whether we had mental health specialists or not, provided you were paying attention to a range of different aspects about the intervention and its delivery that I'll speak about in a moment. In India, Sangath has been pretty much the pioneer in this area, and I'm sure Dr. Bhan will speak a little bit more about Sangath. But importantly, as you can see from this array of different randomized controlled trials, all published in leading journals like The Lancet and JAMA, that essentially Sangath has been working across the full range of mental health problems, from autism in childhood to school-based mental health promotion, adolescence, and a range of mental health conditions all the way through into old age, demonstrating that we can reimagine and redefine mental health care in 4 key ways. First, the composition of mental health care is being demedicalized so that clinically effective interventions such as psychological and social interventions are presented in a manner that is acceptable to our communities. These interventions can be delivered anywhere, but in fact, some of the most radical delivery settings have been in patients' own homes, which is, of course, also the place where many other chronic disease management programs like TB are also being delivered. pretty much anyone can deliver mental health care, especially our frontline workers. And the key here is what I referred to earlier, is having very careful design of how these interventions can be scaled up through competency-based training and great attention being paid then to supervision to assure quality. This evidence is transforming mental health both globally and regionally. The Mental Health Action Plan of the WHO and the Disease Control Priorities Program of the World Bank have embraced this idea of employing community-based providers to deliver mental health care. And importantly, in India, the National Mental Health Policy and also the Mental Health Care Act now clearly speak to the scaling up of this very exciting implementation science knowledge to actually improve access to care across the region. How do we actually do that? So I want to end by telling you a little bit about what Sangath is doing in partnership with Harvard Medical School to transfer this knowledge, which is really largely based on randomized controlled trial, so that we can empower, as it were, the entire workforce in India and across the region to rapidly be skilled up to deliver these interventions at scale. And here we are deploying the power of the digital technology for learning, mastering, and delivering quality assured psychological treatments. Thanks to support from the Wellcome Trust, we had designed a number of different treatments, which I've already referred to earlier. Importantly, from a regional perspective, some of these treatments have been trialed concurrently in other South Asian countries. For example, this treatment, which is for the treatment of depression, it's a 6-session treatment delivered in routine care settings, has also been independently evaluated in a randomized controlled trial in Nepal. We also have a treatment for maternal depression called the Thinking Healthy program that was originally designed and tested in Pakistan, and now we have concurrently shown its effectiveness with peer-supported delivery in India as well. So there's already a lot of regional learning and sharing that is happening. But for now, in the Empower program, we have started with this depression treatment. And thanks to the NIH's support with the Essence program in Madhya Pradesh, we have systematically transferred the entire curriculum and the learning tools from being a workshop-based model, which is the traditional model for training frontline workers, into a fully digitized model with remote coaching. And here you can see a screenshot of the app that Sangath has developed. And currently, we are doing a randomized control trial with the government of Madhya Pradesh, where we are testing 2 different ways of delivering the digital training with and without coaching against the gold standard of the face-to-face workshop with Ashas. And we've almost completed the recruitment of nearly 350 Ashas who will take part in this trial. We are now incredibly taking the same treatment, and this is important to say about the innovations that are coming from our region. This particular 6-session treatment, which is the shortest psychological treatment for depression on record, is now being adapted for delivery in the wealthiest country of the world, which is the US. And concurrently with the rollout in Madhya Pradesh, we also have support from the Tata Trust to enable this to happen. It is also being rolled out with support from philanthropists in the US. So I think maybe for the first time, an innovative new treatment program, which was developed in South Asia, is now being delivered with adaptation in the US and indeed also in Canada. We're also, as Dr. Reddy rightly pointed out, trying to develop new curricula for frontline workers who are engaged in the COVID-19 response to really empower them with the skills for basic psychosocial care in the communities that they are serving. So in doing so, what we're really doing with Empower is moving from naive learners, enabling naive learners like Ashas to complete online learning, to become competent learners, then with case-based learning to master the deliver of the intervention so that they can ultimately become experts. This, I believe, is the only way that the rising demand due to COVID can actually be addressed. The current system is not just a limited supply, but also the demand side barriers was already inadequate even before COVID. It will be completely inadequate thanks to COVID. What we really do need is an empower-based model so that we can dramatically increase the numbers of people whom we can help. This is my last slide. I just wanted to say that I think COVID-19 is a real portal into the failures of our healthcare system. I don't need to say much more about that. It is self-evident. And it's a real historic opportunity for us to invest both in universal health coverage and within that in mental health as a core component of universal health coverage. But it's important to also say that while we need more money, and that's of course goes without saying, we also need to spend it wisely. We must be guided by the best science, and that means embracing the diversity of experiences and strategies which work. Thank you.
Thank you. Thanks a lot, Professor Patel. This was very insightful, very, and I'm sure has set the context for our regional dialogue. I would now request my colleague, Dr. Namrata Pathak, to take over, introduce Dr. Anant Bhan, and we move on with the panel discussion. Namrata, over to you now.
Thank you, sir. And thank you, Professor Patel, for those insightful comments. We'll move on to the panel discussion now, and it will be moderated by Dr. Bhan, who needs no introduction. But let me just briefly introduce you to him. He is a physician with masters in the University of Toronto. He is a researcher in global health, bioethics, and health policy. He's also the adjunct professor, Yenepoya, Mangalore, and adjunct faculty, Kasturba Medical College, Manipal. Anant is immediate past president, International Association of Bioethics, and his work is focused on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community engagement, ethics training for professionals. Over to you, Dr. Anant. Let's begin.
Thank you so much, Namrata, and let me add my words of welcome on behalf of Sangath to all the participants of this webinar. We are obviously delighted to be partnering with RIS for today's webinar with a regional focus on South Asia. Just very quickly, Sangath, for those of you who might not know, the organization is just entered its 25th year of existence. It's an NGO, a not-for-profit, committed to improving health across the lifespan by empowering existing community resources to provide appropriate physical, psychological, and social therapies. And our focus primarily is around child development, adolescent and youth health, as well as mental health and chronic disease. Specifically, this webinar is also being conducted through our Essence project, which is funded by the US NIMH, as a component of which we do capacity building work and also partner with organizations like RIS to push the agenda for mental health in the region. So thank you so much again. The plan for now is actually to go through a panel. As you see, we have convened panelists from the South Asian region who are a mix of academics, researchers, policymakers, service users, community-based organization representatives, as well as providers. And what we are hoping they would do is provide unique perspectives based on their expertise on this question of what are the challenges for mental health in the region which exist, especially in the context of COVID-19. What are some of the best practices they are seeing in their own context, and what are the ways forward? So what we have requested all our panelists to do is to take 5 minutes each as introductory remarks and highlight their unique perspective on this topic. And then depending on the time remaining, we might do a second round of directed questions at the panelists. So rather than introduce everyone together, what I'll do is I'll go sequentially introduce the speaker and then let him or her speak. And then towards the end, we will have a round of discussion as well as Q&A. So our first speaker is Dr. Rohula Amin. Dr. Rohula is a medical doctor who's trained as a psychiatrist, also as a psychologist. He is based in Afghanistan, has taught in the American University of Afghanistan and Kabul University, and serves as the country director for the American Institute of Afghanistan Studies. He has developed a guidebook for trauma counselors and civil society organizations, and has been conducting field research on group psychology and social psychology of intractable conflict with primary focus on Afghan diaspora in Germany. Welcome, Dr. Rohula, and look forward to your questions and comments with regards to our topic. 5 minutes, please. Thank you. Over to you.
Thank you very much for this opportunity. This is a really unique opportunity that I really appreciate, and I am looking forward to learning from other colleagues as well. What I can share from the Afghanistan side is that COVID-19 in Afghanistan was the best way to describe it is another version of suffering in addition to what is going on in there. So as you know, security is something that captures everybody's attention much more than everything else in Kabul and other provinces and cities in Afghanistan. And the COVID-19 pandemic, if I may call it a pandemic, what it did actually is that it added to the problems that already existed in the society and in the system, and already exhausted system and public health system had to deal with something that it wasn't prepared for in any way, shape, or form. And what they could do, but first of all, it wasn't easy to really recognize what COVID-19 was because of a lot of other health conditions that, due to pollution, due to the weather change and a lot of other circumstances, a lot of people had the kind of complaints that were easily mistaken with what COVID-19 should present. So I would say there was a sense of panic at the beginning, but also a sense of despair that really was from the cases that at least I was working with, and some of the ones that other colleagues all over the country, psychosocial counselors and psychotherapists and medical doctors actually reported. But what happened is that the first thing that the Ministry of Public Health could do was to work on education, on, let's say, psychoeducation and health education about COVID-19, of what it looks like, how it should feel like, and what should be done. And the public health system developed guidelines and instructions in several languages, in audio form, video, but also text form. Due to the very low level of literacy, a lot of the messages should have been prepared in terms of the audio and video format. So a lot of the radio channels and TV channels and other mediums were used to communicate these messages to the public. And one of the platforms that was supposed to be used for this education or health education of the public was mosques, because everybody was gathering in the mosque. The first priority was to prevent these big gatherings, but also use mosques as a platform to inform people. But there was one other issue added to the problem, that a lot of the mosques and religious leaders did not actually believe in the health crisis of COVID-19. There was a lot of conspiracy theories going around, and those conspiracy theories were kind of, I would say, expanding on different levels, particularly among those who were more closer to some of the religious circles that would continue these Friday prayers and gatherings, and even expanded their gatherings to a very, very interesting level, and seeing the COVID-19, what they call it, propaganda, as a foreign, stigmatized kind of another way of torturing and abusing the population. And that did increase the number of the infections in the country. But maybe a few things that I can report from the Afghanistan side is that the number of the cases that were recorded as infections were really high. So the number of infections were really high, but the mortality rate was really low. And a lot of the public health professionals were asking, why is that? Is it about the reporting? Is it that the data is not really accurate to the way it should be? That we don't have these data doesn't match, or is it some other way of understanding that is there some sort of resilience in the country that we don't know about? A lot of speculations was made because that there was the BCG, for example, vaccine is something that is very much used in the country, of course, because tuberculosis is not totally eradicated, at least in some of our countries. So some people thought that maybe it's BCG vaccination that creates some sort of defense for the coronavirus. And other speculations were going on as well. On the other hand, one other problem was the stigma of corona infection, that a lot of the families and people did not actually want to report corona infections. And it was seen as something that in the very early days, or maybe several centuries ago, like leprosy was seen as a very stigmatized health condition, that the patients were supposed to be isolated and treated a certain way, like some of the mental health issues that are treated with the same kind of attitude. And these the stigmatized notions actually force people that even if there were deaths as a result of coronavirus, they would not report it, or they report it as another problem, as a heart attack, or someone died as a result of the heart attack because they didn't want the funerals to be empty or nobody would participate in burying a loved one. And a lot of the ceremonies like Eid and Nowruz and a lot of other happy holidays were really hindered, but also there were families who really went on and celebrated as much as they could. So, and medical doctors started to I can't say misdiagnose, but a lot of the medical doctors started to label coronavirus symptoms as something else. So some give the brucellosis, for example, diagnosis for corona patients, and some give other types of diagnosis for patients that maybe in one hand that stop people from panicking, but on the other hand, medical doctors did advise them to give them all the instructions that a corona patient should have, but also in addition to some medications. But in Afghanistan, at least the budget for the public health is a very small portion of the overall annual budget of the government. It's about 5%. And the budget for the mental health services is even a much smaller portion of the public health budget. So in terms of the capacity, there wasn't a lot that could have been done. But despite that fact, there was a lot of hospitals activated, a lot of the tests were delivered, mostly by the public hospitals, but later on, the capability was transferred to the private hospitals and clinics to deliver the tests. I would say what happened actually in Afghanistan, the way corona pandemic was perceived, was that there were hierarchies of pain and suffering, that people would calculate every day that, oh, there were lots of ways of dying here. Bombs are one, suicide bombers are another one, rockets are another one, and disease is another one. And there were lots of people whose lives and families' lives depended on them getting out and doing something for work and getting back home with some income or food for their sustenance, which was why a lot of people could not actually take corona pandemic seriously. There were for a month and a half, there were restrictions on movement imposed, but it didn't work that much because the government needed a lot of movements, but also people moved. And then about 2 months later, schools were opened again. But yes, I would say there has been a lot of things that we learned in Afghanistan. That first, the data collection system was not what we wanted it to be. So our data collection, the connection between all the central and provincial health services needed to be improving. And there was a lot of support coming from the outside, from the national agencies, but also about, I think it was $70,000 what the government could afford to allocate to fight coronavirus and help families with some food and other kind of immediate needs so that they will stay home.
Dr. Amin, can I request you to maybe wrap up here in the interest of time so that we can get through all the panelists?
I'm done. The main big picture is that there was this calculation maybe is an interesting thing that might be very different comparing to other countries in the South Asia, that the calculation of pain and the hierarchy of suffering was something that was unique in Afghanistan, at least, that people were dealing with a lot of other types of issues, despite the fact that Corona was also one of the priorities that was introduced to their lives. Yeah, that's it. Thank you.
Thank you so much, Dr. Amin. I mean, that was, obviously it's difficult as it is in situations where there is conflict, and your point about the hierarchy of pain and suffering obviously drives through the importance of looking at these issues besides the issues of stigma and infodemic that you talked about. Thank you so much for your comments. Our next speaker is Mr. Mohammad Kamruzaman, who is a senior research associate at the Center for Policy Research at Dhaka, Bangladesh, and is also a global fellow at the Watson Institute for International and Public Affairs in Brown University in the US. He holds a master's degree in public policy from the National University of Singapore and has been a policy analyst and economist who's been working with think tanks, international governments, and public health institutions. Mr. Kamruzaman, over to you for your insights around how COVID-19 and mental health have been impacted in Bangladesh specifically. We're not able to hear you. I think you're still muted. Can you try speaking now and seeing if it works? No, unfortunately, I don't think we can hear you still. Just in the interest of time, maybe I'll just go to the next speaker and we can come back to you. And someone from the tech team at RIS will reach out to you to try to figure out if we can do some problem solving there. Sorry about this, but these tech issues happen sometimes with webinars. If I can request Professor Pushpa Prasad Sharma, who's a professor and head of the Department of Psychiatry at the KIST Medical College at Lalitpur in Nepal, to kindly speak next. Professor Sharma has done his MD in psychiatry from the PGIMR in Chandigarh, and he's been attached with various national and international psychiatric and social organizations and has published more than 30 research papers in national and international journals. Professor Sharma, we look forward to hearing from you about how the situation is in Nepal and its impact. Over to you, sir.
Thank you. There is some problem with the internet.
We can hear you now, sir. Please go ahead.
Can you hear? Can you hear me?
Yes, we can hear you, Professor Sharma. Please go ahead.
Hello. Thank you, RIS and Sangath, for having this program organized, also having me in your program. Like in most of the South, Nepal is also fighting the pandemic and the impact. You see, widespread disruption of the mental health network system that was so inadequate even before the pandemic that has put pressure on the different mental workers in the community, and that we have to face a lot of that in mitigating this mental health response of the pandemic. From the beginning of the pandemic, we plenty of anxiety symptoms, plenty of depression, and also there are some data that may suggest that the suicide rate has also gone up, but that data has to be analyzed adequately before we come to a conclusion. I would like to highlight, major problem in delivering mental health facilities in Nepal is that this mental health has never been a priority in policy, and that it always had a very poor resource allocation. But this pandemic has sent a wake-up call to the policymakers, and policymakers are now responding, if not adequately, but at least started responding that this mental health problem has to be addressed. And if not, then society has to pay heavily for this, and that the burden of care will increase by many folds. So government has taken some initiatives, and also the other non-governmental organizations also have started taking initiatives. The rate in delivering mental health services. That first is, of course, I have mentioned about the poor resource allocation. That I hope will increase in course of time, that a policymaker will realize, and that they'll start allocating adequate budgets, adequate resources to the mental health need. Another point that has been mentioned by the previous speakers also about the stigma. Stigma not only has, is a major barrier in delivering mental health in Nepal, also to the poor utilization of existing mental health services by, and that we have to fight this major barrier in delivering mental health network, or the mental health system in Nepal. Apart from this, as you know, Nepal is a country which is relied mainly on the employments, that the tourism has gone totally down for the last 8-9 months when this pandemic started, and there is a lot of unemployment due to this the problem in tourism. So the hotels are closing, restaurants are closing, so they don't need manpower. So this unemployment is really increasing the mental health problems of the community, of the society. And that what we need to do, that is that what Patel told, that only the biomedical, but also to train, make level health worker adequately in giving psychological first aid or mental health gap, so that even in remote areas where we don't have adequate number of mental health workers, they can give at least psychological first aid and do basic counseling. So that we are trying to do, and I think there are so many things that we can mention. It's just a very little time to talk about all these mental health issues in this country. And of course, one more thing that has taught us learned from the mega outbreak and its mental health response. Of course, it was in a very limited geographical area, but that has really taught us how to address the post-disaster mental health problem in the community. So main area is that we have to teach the community how to cope and how to be resilient. I think my time is over. Thank you very much.
Thank you so much, Professor Sharma, for highlighting issues around shortage of budgets, the fact that there is often a poor utilization linked to the fact that there is stigma, especially around mental health access, and the fact that while communities are often impacted negatively, it can also be that we can work with communities for enabling response. And I appreciate all of your comments. If we can move on to now our panelist from Sri Lanka, Ms. Sunimali Madurawala, who's a research economist at the Institute of Policy Studies in Colombo, Sri Lanka. Sunimali holds a BA from the University of Colombo, Sri Lanka, and has over 15 years of research in the area of health economics, gender and population studies, and has been a consultant to multiple bilateral and multilateral agencies as well as private foundations. Over to you, Sunimali, and we look forward to hearing from you on how the pandemic has been impacting Sri Lanka and the response there.
Good evening, all of you, and thank you, Dr. Anand. Can you hear me?
Yes, we are able to hear you. Please go ahead.
Can you hear me?
Yes, we can hear you. Please go ahead.
First, let me share my thoughts on COVID-19 impact on mental health as highlighted. Yeah, okay. First, let me share my thoughts on COVID-19 impact on mental health. As highlighted by the other colleagues of the panel, the pandemic has affected every aspect of our day-to-day life. Because of the COVID-19 preventive and controlling measures such as social distancing, lockdowns, quarantine curfews, and restrictions in mobility, people are compelled to adjust their lifestyle according to the new normal. Economic activities, social activities, and religious activities are badly affected, and they are restricted mostly. And most importantly, because of these conditions and restrictions, mental health of the people is severely affected. The scale of lockdowns and other controlling measures around the world is unprecedented. That is why the issue of mental health is important. People suffer immensely from the loss of employment, the deaths of family members and friends and other community members, the physical effects of infection, and the mental trauma and fear. And accessing mental health services during pandemic situation and prevailing stigma on mental health issues in general, and as well as stigma on infection of the virus are some of the major challenges related to mental health under this pandemic situation. Now let me give a brief introduction on mental health status in Sri Lanka. Sri Lanka provides free healthcare through the government system to its entire population, that is nearly 21.3 million. Sri Lanka has made a commendable progress in achieving most of the health indicators in recent past. In fact, Sri Lanka has been regarded as a model country for many decades in terms of high quality population health outcomes with relatively lower investment in health. But despite these remarkable successes in achieving general health indicators, we could see that the attention to mental health of the population and the mental health system was not so impressive in the country. It is said that the condition in the mental hospital in the country were among the worst in the world, and there were virtually no community mental health services in most parts of the country. And also mental health care in Sri Lanka was affected by lack of funding, scarcity of trained mental health professionals, over-reliance of tertiary level hospitals, and limited mental health resources outside of the urban areas. because of this, suicide, depression, substance abuse, gender-based violence, and the breakdown of social structures and family units continued recording as major mental health issues in the country. And this status was worsened by two major incidences. That is, one is the 30 years of conflict in the country that ended in 2009, which that had a significant impact on mental health of the people in Sri Lanka. And also the country was also devastated with massive loss of life and population displacement by the Indian Ocean tsunami in 2004. However, we can notice some progressive developments in the improving mental health of the country in recent years. And some of those developments are like a high level of political commitment towards improving mental health in the country. This is especially after the tsunami that the country has experienced. There was an increased political commitment to prioritize mental health services in Sri Lanka. And also in 2005, the mental health policy of Sri Lanka was approved, and the policy introduced a decentralized and community-based system of mental health care. And also the policy introduced major changes in the into the organization of the mental health services by moving away from institutionalized mental health care towards care at the community level. And also in recent years, we could see more allocation going for development of mental health infrastructure of the country. And there are some programs going on, like recruiting the community support officers, mainly in the tsunami affected areas, and also improving the quality of the healthcare workforce who are working on the mental health. Those are some recent initiatives in improving mental health of the status of the country. And with these changes, I would say that the country is more focused on developing the mental health status of its population. However, the pandemic situation has definitely placed a huge burden on the mental health status and the system of the country. And it would be really challenging for the system in facing those issues. Thank you.
Thank you so much, Ms. Sunimali. If I can now loop back to our panelist from Bangladesh, Mr. Mohammad Kamruzaman. I think his audio and video are working now, so that he can make his comments. So over to you, Mohammad.
Yeah. I hope you can hear me.
Yes, we can hear you. Please go ahead.
Great, thank you. So thank you for giving me the opportunity to contribute in this discussion, and thank you RIS for organizing this important and much needed discussion on mental health. So I'll start by sharing some country experience from Bangladesh. So from a 2014 study, we see that there's a prevalence of mental illness in Bangladesh among adults, which is in the range 6% to 31%, and among children, it's around 13 to 23%. Now, because of the COVID-19 pandemic, it has brought enormous psychological stress on people from all walks of life. In that regard, it is likely that it has worsened the situation. For example, an online survey in Bangladesh has found that almost 84% of pregnant women and 74% of mothers of infants, respectively, were found to be suffering from the severe psychosocial impact of stress. In this regard, there have been steps taken by both the government and non-state actors, but it has been on a limited scale. For example, the government of Bangladesh has come up with a guideline for addressing mental health during the COVID-19 situation, which it kind of recommends use of psychotropics for mental health. for COVID-19 and also management of mental health issues in ICU patients with COVID-19, and also online telepsychiatry and telecounseling service from the mental health professionals to prevent and combat burnout among healthcare providers. In that regard, healthcare providers around Bangladesh have received mental health support to cope with COVID-19, and it was with support from UNFPA. Several NGOs and private institutions are also providing telecounseling helpline in Bangladesh, but these remain in a very small scale. Now, in terms of the regional experience, we can see that the share of health expenditure in GDP in the South Asian region has been around 2% on average in most countries. And since the healthcare services are provided in a very urban in the urban sectors, 80 to 90% of the population usually don't have access to treatment. And lack of skilled service providers is also another issue, as it was mentioned earlier. So in this regard, I want to highlight the need for integrating or using primary healthcare providers in providing treatment for mental health services. Now, this kind of projects have been implemented in many countries, including Nigeria, Chile, Brazil, Iran, and India as well. And those have given some sort of, they have given positive outcomes. And under these projects, general practitioner, physicians or primary physicians, trained medical officers, and the treatment, and patients also receive support from their family as well. So this is more of a community approach, and they also receive the service from primary health sector as well. And as it was mentioned earlier as well, lay health workers, community health workers, important in this regard. There has been one project in Jammu Kashmir in India where lay health workers were trained to identify critical mental disorders based on World Health Organization identified criteria, and they were they did pretty well in communicating on a weekly basis with patients using cell phones, as well as assessing them using digital technologies such as notebooks. In Bangladesh as well, there's BRAC, the largest NGO in the world, is also running a humanitarian play lab in the Rohingya refugee camps. You're aware that almost 1 million Rohingyas are being hosted in Bangladesh. So these humanitarian play labs actually provide learning and healing through play to the traumatized children, and the mothers of infants as well receive some sort of psychosocial counseling as well. So these are some projects which can be scaled up in some way through furthering by more finances or with a little more evidence as well. In terms of building awareness, it is really important that mental health is kind of sensitized in the region. Now, many speakers have previously identified that there's a huge stigma around mental health in these issues. So in that regard, going to the communities and and using the community leaders, particularly the religious leaders or the political leaders in those areas, to sensitize people would be really important. And most importantly, you need a lot of social marketing in that regard. For example, there are many successful cases from Western countries as well where it has worked. So we can kind of replicate those and tweak them by introducing or by integrating the local knowledge as well, or what can work and how it can work. So all those issues can be can work in the region. In conclusion, I want to highlight that all this needs to be done by sharing the best practices across the region. So think tanks and other research organizations should come together and highlight what has worked and how it can work. Most importantly, one of the things that has been lack of finance. Now, I think one area where we can work is the climate fund that is lying there. So in this regard, we have to be a bit more innovative while using that fund. What the problem with that fund is that you can't get fund unless you can connect it with climate change. Now, there are hundreds of research lying around which shows that climate change actually causes certain sort of natural disasters and other issues are coming up. For example, prolonged flood or loss of yield, which causes a lot of mental stress. Now, even if we are currently in the COVID-19 pandemic, the next thing that we need to worry about as well, which is currently ongoing as well, is the climate change issue. And that thing also has a lot of consequences. A lot of research shows that the potential for huge economic losses, and this will have a lot of mental health impact as well. So in that regard, this vision as a whole needs to come together to identify certain projects and connect them with the climate change issues so that those can be implemented throughout the region. And in that regard, consortiums can be built, like let's say like NGOs or other development firms from India, Bangladesh, and Pakistan works together to solve this issue or implement certain projects which can help in this regard. The second thing is like use of digital technologies, particularly the use of phones and other digital technologies to provide healthcare services to remote communities where it is very difficult to send down doctors or other healthcare practitioners. So this can be really useful. So most importantly, we need to incentivize frugal innovations so that those remote communities and resource constrained communities can be reached with the low amount of resources and with high impact projects. And I would like to conclude by quoting one researcher who has mentioned that the major hurdle in providing mental health care to the community seems to lie not in the purse but in the mind. So we have to be very clever and very innovative in terms of coming up with projects so that we can cater to the needs of the mentally those who need a lot of mental support and mental health care. Thank you.
Thank you so much, Mohammed, and for highlighting the role of digital technologies, but also the challenges around financing and where some of that innovation can lie. And hopefully it's for emerging scholars and leaders, young leaders like you and Sunimali, to hopefully bring about that change in the region by pushing our governments to spend more on health and specifically also on mental health. Thank you for your intervention. We now move on to our next speaker, Professor Surinder Jaswal, who is the Deputy Director at the Tata Institute of Social Sciences in Mumbai, where she's also a professor at the Center for Health and Mental Health at the School of Social Work and the Dean of Research and Development. Professor Jaswal holds a doctorate in public health from the London School of Health and Tropical Medicine and has been for many years working across public health and mental health with a focus on health inequity, women's health, and disaster and social work education. Thank you so much for joining us, Professor Jaswal, and over to you.
I'm audible? Am I audible?
Yes, we can hear you. Please go ahead. Yes.
At the outset, I would like to thank the organizers, Professor Chaturvedi, the RIS team, particularly Dr. Pathak, for initiating this, because I think it's really, really needed. It was very good to hear Dr. Reddy and Dr. Vikram Patel lay out the landscape with regard to the mental health impact of the COVID-19. And I think my preceding speakers have also highlighted very well what has been the impact across the region. And I would like to say that the impact has not been very different, given that our region is quite similar. In the interest of time, what I'm going to try and do, instead of repeating things which have already been said, I'm going to try and present a couple of brief, not case studies, but best practices which my university has initiated, and through them highlight the gaps as well as the way forward. The Tata Institute of Social Sciences, where I work, is a teaching research university, which also believes in social change. And we have a large number of field action projects, and I'm going to share with you all two initiatives of which we call the field action projects. One, which is through the Center for Women and Girls, which addresses domestic violence since 1984. These are situated in the police cell so that women can come and report the violence that they have been facing over a period of time. Now, when we looked at the data set in 2019 of women who were reporting domestic violence in April, May, and June, and we compared it to a similar period in 2020 when the pandemic and the lockdown was imposed. When the pandemic happened and the lockdown was imposed, we find that there was around 14% increase in the reporting of violence by women, even though in 2019, face-to-face reporting took place, and during 2020, it was online or helplines which were used. But what is interesting here, and something that we all need to note, is that besides the 14% increase of were able to access some form of help in order to report through a helpline, most of them spoke about the fact that please give me ration, give me food, tell me how do I step out, what do I do in order to get some time and space for myself. I'm not reporting only about violence, but they were talking about various correlates of violence which were impacting their mental health as well as other structural issues which the family was facing and which in turn was cascading onto the women. The second one I want to share is about a helpline that the institute runs, the university runs, called ICON. We have a helpline which was initiated a few years ago for young people, particularly young people who needed information or who were calling in to report self-harm in order to prevent the increasing suicides that one found in academics and related areas. And we added to the helplines because we realized that the number of calls that were coming in on the regular helpline had increased to over 2,000 per month. Over 1,500 emails and 500 chats were being reported by regular callers. When we introduced a second COVID-specific helpline, we found that genuine COVID-related calls were over 600 a month. And here again, we found that the people who called in were calling to report certain symptoms related to mental health, but they brought our attention to the fact that they were facing loss of livelihood, they were having anxiety due to education being disrupted, fragmented due to other medical and so on costs, and asked for help in those areas and not necessarily the symptoms that they were facing. This forced our team to look at not only the emotional ramifications which the clients or the people or the population that was using the helpline were calling in for, which were resulting in the emotional ramifications during the pandemic. We also realized that cold reference, merely referring the person to another group which would provide the required service, was not proving to be useful, and what was required was active follow-up, a facilitative process by which people who were calling in for mental health needs also received services in the areas that they were calling in for. A third helpline was initiated by the Institute because we realized the need for a dedicated helpline for frontline workers. And all of us know that the frontline workers' lives were mirroring that of their clients, their patients, with regard to mental health issues. Large number of them talked about burnout issues, stigma, discrimination, etc. So if you see the increase in the kind of service that was provided, which was in response to the gap that the health system was facing, we had a regular helpline which was being oversubscribed in a way, a COVID-specific one where people were calling in for structural help besides the mental health issues, and a frontline workers dedicated helpline which was also inundated with calls. A fourth one, which was initiated in response to a gap that was identified, was for consultations. And here it was felt that governments and other groups needed support in starting services. They identified gaps but were overwhelmed. Systems were overwhelmed with regular care as well as responding to the changing need during the different phases of the pandemic. Providing consultation to the two systems as well as helping them to update data on websites, for example, of governments and so on, became one of the key areas in which we intervened. Another one which I would like to talk about is the capacity enhancement, where mental health professionals who had been working in peacetime now needed to move to crisis time and upskill their capabilities in order to be able to respond adequately. So this capacity building or capacity enhancement helpline was initiated to train mental health professionals, government professionals, NGOs, non-governmental organizations who wanted help, as well as private organizations on self-care, community care, etc., and upskilling. So what we find is that in our own journey through this, there are 33 field action projects that the Institute intervenes with, and we have, kind of best practices from each of them, but I've decided to stick to 2 for the moment in order to highlight some of the key issues that this throws up. What we realize is that the concept of mental disorders, mental illness, moved from mental disorders to mental health to psychosocial care and support, which recognized that in countries like ours, where you have a very diverse population, many a time people face stigma and exclusion because of identity-based exclusions. So it's not just stigma and discrimination because the person is having mental health, but also the person per se. Who is that person? Where does that person live? Etc. etc. also colors the way we respond and whether the person can even access services. So from psychosocial care and support to what Professor Chaturvedi said earlier, I think we need to move to a more integrated intersectoral response, which is well-being and wellness-based, where we recognize intersectionalities, where we recognize structural inadequacies, we recognize the cause of stigma, discrimination, etc. Lot more that I want to say because this is one of my favorite subjects. I can see Anand looking anxious. Give me half a minute only. So I want to say that in 1992, when the World Development Report for the first time talked about the burden of disease and brought focus to mental health as against only physical health, a number of my colleagues from the field of psychiatry always complain that mental health has always been the other brother or sister or the step brother and sister. I think this time during the pandemic, during COVID-19, unlike disasters and unlike earlier pandemics such as HIV, AIDS, and so on, it is helping us to visualize the correlates which are important for us to center stage mental health and to truly own what I call public mental health. To remove mental health from facilities, from only acute response to only chronic response, to a far more ongoing response to the needs that people face, and which is not related only to organic factors, but to the way people live and how people are pushed to live. There's a lot more that we need to talk about, but I will stop here. Thank you, Anand.
Thank you so much, Professor Jaswal, for bringing focus to some of the data from all the work that TISS has been doing, as well as your own perspectives around how we can enlarge some of these conversations and look forward in terms of reforming the way we address mental health and the development discourse. Very much appreciated. If I can now invite Dr. Ishwar Basavreddy to go next. Dr. Basavreddy is the director of the Morarji Desai National Institute of Yoga in New Delhi, holds a master's degree in physics and a PhD in yoga philosophy, and has for many years been working in the area of yoga education, training, therapy, and research, and has also been working with RIS on traditional medicine and the role of yoga. Over to you, Professor Dr. Ishwar, please.
Namaste. Namaste, Dr. Anant Bhan. My Professor Sachin Chaturvedi ji, and also Neeraj Jain and other my colleagues. I'm very much delighted to know the different aspects, and especially the inaugural address, and Professor Vikram Patel has come up with many wider dimensions in his keynote address. And I'm very much delighted to know the data given by my colleagues from different countries. Just to inform, I am the director of a premier yoga institution of Government of India, and also the advisor yoga and naturopathy to Government of India. And on that basis, I would like to emphasize on the initiative taken by Ministry of Ayush, which is we have 2 systems in India. One is health and family welfare, where modern medical system is there in the place in different parts of the country, and we have Ayush system where more than 8 lakh registered practitioners and yoga naturopathy practitioners are also there who are not registered yet. So with this wide range of these things, we have a well-established healthcare delivery system. And now I'm particularly belong to Minister of Ayush has taken several initiatives. Just I will point out 3, 4. Then I emphasize on what the initiative has taken by the ministry and my institution exclusively on yoga and in the present pandemic condition on mental health. What is our subject? Most importantly, Ministry of Ayush has 7 systems: Ayush, Ayurveda, yoga, naturopathy, Siddha, Unani, homeopathy, and Sevarupa. In all 7 systems, we have released a model protocols for the COVID conditions. In yoga also, we have a 3 types of protocols. One for the entire population, where for the wellness, for the prevention, and overcome the stress and anxiety, and also for the maintenance of mental health. We have a 45 minutes of well-designed, well-established with with premier institutions like NIMANS and other institutions. And on the basis of that, we have come up with a 45 minutes yoga protocol for the general population, and with giving a several. This is one. Is my institution particularly has taken up a research projects on the healthcare workers who are coming in contact with the first-hand contact with the COVID patients, the doctors, nursing staff, and Safai Karmacharis, and others who are coming in contact with the COVID patients. I will elaborate on that. The third one is directly we are teaching to the COVID patients. COVID patients institution itself in Delhi has taught more than 8,000 COVID patients, both at the COVID centers and also home quarantine. And in the beginning, in the month of 3 months of lockdown, we have trained online more than 3.5 or 3.75 lakh people through online. And this is one institution. In India, there are more than 25, 30 many leading yoga institutions like your Patanjali Yogapith, Art of Living, Yes Vyasa, Kaival Dham, Santa Cruz. There are many leading yoga institutions. All these yoga institutions are conducting yogasana classes, pranayama, meditation, relaxation, etc. And there are huge number of millions of people. So we are collecting the data. Millions of people have been benefited, and this is one of the important thing which will help us to develop the immunity. The second most important thing I would like to tell you, one pilot project. Now we are going for the multicentric studies. That is on the study is on the type of effect of pranayama on positivity rate in people exposed to COVID patients, and also effect on mental health, that is stress and quality of life questionnaires we have come up with. It is a 125 controlled and 125 experimental group. For your information, this is a protocol of 30 minutes in the morning, well-designed 5 pranayama practices and meditation, guided meditation. And in the evening time, we prefer some 4 breathing practices and also relaxation, 15 minutes. Total 45 minutes in a day for 28 days. And it's a very 3 months I personally practiced it, implemented. Then we have advocated in the month of August, September. So very interestingly, out of the control group, 9 have got COVID positive, and in the entire experimental group, 1 person only has got a COVID, but that girl is also not practicing yoga regularly. That is one important thing I would like to emphasize. That means, particularly in my opinion, the pranayama will regenerate, and evening breathing and relaxation technique will reduce the carbon dioxide concentration, and also help in a better sleep, quality of sleep, which will help to improve the immunity. Then most important, quality of life, scores of quality of life with a separated in all 4 dimensions: physical, psychological, social, and environmental, both in experimental group, and we got a very highly significant increase in the physical and psychological quality of life scores in the experimental group compared to the control group. So elaborated the number of individuals showed their antibody test first also. I have been. Then most importantly, the well-being index, mental health well-being in the experimental and control groups before and after administration of the yoga module, which showed small increase in the positive mental health scores in experimental group compared to control. So that means where we want to mental health scores in experimental group. So most importantly, we are now in consultation with mental health experts. We are revising our protocol a little bit, emphasizing on some of the postures which will help for the better breathing, and also help for the very good meditation for 10 minutes. So with that one, definitely we are going to have a better results on the mental health well-being index and also quality of index. So what we'd like to say, so yoga, particularly the pranayama, and that is also ratio based. So the inhalation, retention, and exhalations, and there is a particular ratio. I will, if member people want, I will share the details. Was what we developed, and for these things, and thousands of people are now being practiced, and they have been benefited. We got very encouraging words who are practicing this. So as you know that whenever we do half an hour proper yoga practice, it brings down the sympathetic activities and also stimulate the parasympathetic. Then this sympathetic and parasympathetic balance will help in the many way of the health parameters. So this is the another research we are doing it, and definitely would like to share. Then third most important, we are the WHO CC Collaborative Center in Traditional Medicine Yoga, and this is the second term, and this is the only one yoga based CC, and we have come up with 6 protocol, and now we come up with a yoga for well-being YUM app. M app we have prepared, and within few months or few weeks it is going to be released by the WHO. And lot of work during last 8 months we worked out. Then apart from this, our ministry has done a lot of work with AYUSH. We have a MOU with the Department of Biotechnology and CSIR, and a pre-clinical studies has been on the COVID interventions. So 4 oral interventions has been developed by Ministry of AYUSH. That means it's not only the yoga, breathing, pranayama, and etc. Ayurveda interventions, and there is a high power committee headed by one of the chief scientists, none other than the Niti Ayog Vice Dr. Pal, and he's also the one of the member. My secretary is also a technical person, is guiding from the front, and lot many works are going on to integrate AYUSH intervention with a modern medical, which definitely help bringing the quality of change life, and wellness index and mental health status is going to be changed. So with this, if my other panelist is ready, I am ready to share the protocol developed by our institute, particularly on pranayama and relaxation techniques. Very high standard videos we have prepared, and results also I have not put up in the presentation, but I am ready to share my research papers which are going to be published, and also AYUSH interventions in the management of COVID, which are very cost effective. With these things, in the days to come, only one message I would like to say. This is integrative medicine is the future. Therefore, particularly yoga. Yoga means it's not only physical exercises. It has majorly 4 components. One is detoxification practices. So the second one is the body alignment through asana, breathing mechanism management of breathing with pranayama, and mind and emotional management through meditation and relaxation techniques. So they are well defined and established. There are more than 10,000 research papers published in peer-reviewed index journals during last more than 3 decades. So on that basis, we have developed a very well developed protocols which are going to be published by WHO in the near future, and we are ready to share it. And yoga is going to play a pivotal role in the management of mental illness or mental health, in the maintaining the mental health in the pandemic conditions. Thank you very much for the opportunities. So I am open for any discussions at the end. Thank you very much.
Thank you so much, Dr. Basav Reddy. Very interesting to know about all of the initiatives which are happening from both the Ayush and Yoga side, and look forward to seeing some of that evidence being published soon, being shared widely. Thank you for your inputs. If I could now move to our next speaker, Subrata Prakash. Subrata is a unique panelist because she's not only a policymaker, as IRS officer and Indian Revenue Service officer. She's also one of the directors at Niti Aayog in New Delhi, but also someone who's a mental health service user and an advocate. She is a prolific writer on issues related to mental health and has written a book called The D Word, A Survivor's Guide to Depression, and herself has lived experience of major depressive disorder and anxiety disorder. Thank you so much for joining, Subrata, and over to you.
Very good evening to all esteemed panelists, and I hope I'm clearly audible to everyone there. So first of all, thank you very much for having me on the panel today. And after hearing the panelists who spoke before me, who spoke so beautifully on all the aspects of data, as Dr. Bhan said, I am a survivor of depression and I have anxiety disorder. I live with it. I also have attention deficit disorder, and I am that person with mental illness, that person with psychosocial disability that we have been all talking about. And hence, what I would like to do is move a little down from the bird's eye view of policy making that we have been talking about so far, and focus on the individual, the person with mental illness, the person with psychosocial disability, who is at the very heart of it, at the very focus of all the discussion that's happening. Now, from my perspective, as someone who has, lives with psychosocial disability, let us just have this one life. And for me, I think it's my opinion and it's my belief that as an individual, I have the basic human right to live a life which is as functional as possible. And it is to that, towards that end that I feel that whenever we are talking about policy making at a larger level, we definitely need to look at things also from the individual's perspective. Because for me, I am not just a statistic that we are talking about. I am not just a data set or a data point. I am a living, breathing individual. And my life is not just about my economic productivity. Of course, I am a productive member of society. I am an officer. I am doing my work. I'm contributing in the formal economy in the way possible. But then again, as I said, I'm also an individual. I've given birth to, and I'm bringing up 2 future citizens of the world. I'm also taking care of 3 senior citizens, and I do a lot of mental health advocacy. I write. I'm trying to fight the stigma that exists around mental health, and these are very important things to keep in mind, to focus on when we are making or proposing any kind of policy which covers mental illness or people with mental illness. Now, as far as the treatment gap is concerned, I think I say this for all of us here, including the esteemed panelists from other countries, that we who live in South Asia, we all do live in, let us say, a low resource setting, because we are not a very prosperous region. There's no secret about it. And, we do experience a lot of issues with accessing mental health care. mostly because on account of 2-3 factors. One, of course, is the high population that we have, the very big, large population, and the resources that we have are very, very little in comparison with the big population. But another factor, which is the unseen barrier, is the stigma. The stigma and the complete lack of understanding that exists in society as far as mental disorders or mental health itself is concerned. And this barrier prevents people from accessing mental health care. Now, I do a lot of informal, nudging or counseling to people in my immediate circles. In fact, because I have been one of the few people who've been very open and very, outspoken about my own experiences, I have not kind of tried to hide it ever. So I'm one of the few people that, people know they can talk to about a certain crisis that may be going on with them or in their family. And believe me, it's so difficult to explain because there is very little understanding about what goes on inside the mind, inside the brain of someone who has, let us say, a disorder like depression. And, people are more willing to go to a counselor. They want you to couch the reality in very rosy words than actually going to a psychiatrist. Whenever I suggest that, maybe you could try going to a psychiatrist, or if I try to label or, of course, not diagnose because that's not my job, but maybe try to suggest to them that, okay, why don't you go and see, maybe this is depression, maybe this is so-and-so. And these very words, they really put people off, and people sometimes just bolt as if I'm talking about something which is unmentionable. So this is one thing which I really believe needs to go. And this can happen only if more and more of us talk about mental health and we normalize the conversations around mental health. I've also seen that a lot of times when I try to speak about mental health, people get very uncomfortable and, there'll be very embarrassed smiles, and then somebody would try to change the topic. So that is something that maybe with time, with a little more patience, perseverance, that thing has to change, because even if the resources are available, whatever resources are available, people are not really taking advantage of those. And I will admit very freely that I am one of those people. Even with the certain amount of education and privilege that I had in my background, for 5 years, I was not even aware that what I had was major depressive disorder, which had been triggered postpartum. I first had postpartum depression, which later on became major depression. So if this happened to someone like me, imagine someone who lives in a much less privileged, who lives a much less privileged life, and that person probably would not even have the resources or even the language to express what they're feeling. And we have to bring down the level of conversation so that it's all persuasive and everyone gets to know what is happening. Now, the third thing that I would like to talk about here is, well, COVID has already been spoken about by so many people. And incidentally, I'm also on the intersection because I have psychosocial disability, and then I also got COVID and I survived that. And fortunately, since my symptoms were very mild, so surviving those 15 days of isolation was the most difficult part of me. And there was threat to, I'm vulnerable because I already had pre-existing conditions of mental health, mental disorders. And I used to feel under pressure sometimes. I was really afraid that I may just slip into depression again. But thankfully that did not happen, simply because I had the resources of everything that had helped me to recover in the very first place. So COVID has been a major disruption in everyone's lives, and people have had to worry about things like, where is my next meal going to come from their very livelihood, to people who had more privilege but who kind of worried about their mortality, that am I going to survive this if it comes to that, or what about my loved ones? So people have been between all of this. And if in that case, COVID has been a trigger, a very big trigger, a significant trigger, both in terms of magnitude as well as its wavelength, because it has hit so many people all around the world. And at such times, I would just like to say two more things. That first of all, let us acknowledge that there is a problem. Let us acknowledge that what we are feeling is distress, what we are feeling is anxiety, and also the fact that it is absolutely normal. It's you're not feeling okay. It is kind okay, because it's okay not to be okay. You shouldn't have to feel ashamed of feeling anxious or sad or low. And if you move on to the stage when you actually become dysfunctional, you must access the treatment that is available. And the second thing is, for everyone who's listening anywhere, please be a little kinder to everyone around you, because COVID has underlined and amplified the biopsychosocial model of mental disorders more than anything else. And that social part is something that maybe we can really make a difference by just being a little kinder to everyone around us. So that's all I have to say for now. Thank you to Dr. Bhan, thank you to Professor Chaturvedi, and a special greeting to Dr. Patel, because anyone who's a part of the mental health community, for us, you are a legend. So it's been a privilege to have been on the same panel as you. Thank you very much.
Thank you so much, Shubrata, for, I guess, highlighting that it's okay not to be okay. And also probably from a mental health advocate perspective, the fact that nothing about us without us. And I think those are really important messages for us to also convey through this panel to everyone who's watching. Our next panelist is Susan Thomas. Susan Thomas is the National Health Coordinator at the Self-Employed Women's Association, commonly known as SEWA. She also manages the child care department at SEWA. Susan has been a part of the health and development sector in India for many years, decades actually, and has worked with a variety of organizations and has served in various capacities and brings in a rich body of experience working in the health and development space, and especially from a community-based perspective. So over to you, Susan, for your thoughts around how to address this issue, especially from an NGO and a community-based organization perspective. Susan, are you able to connect? We can see you now, but we are not able to hear you yet. Can you try unmuting yourself? Okay, we can see you, but I don't think we are able to hear you yet. There is probably an issue with the microphone. No, still not yet, Susan. So what I'll do is, Susan, if I may just move on to Professor Jain and come back to you. And in the meantime, the tech team will try to reach out to you, try to address this issue. Our next panelist is going to be Professor Neeraj Jain. Professor Jain is the director at the National Brain Research Center located at Manesar in Gurgaon, India. Professor Jain holds a PhD from IARI New Delhi and received his postdoctoral training at Vanderbilt University in the US, has received an International Senior Research Fellowship from the Wellcome Trust, is a fellow of INSA as well as many other science academies, and has been working extensively in the field of neurosciences. Welcome, Professor Jain. Thank you for joining us, and we look forward to hearing your perspectives on this matter.
Well, thank you very much to Dr. Bhan, RIS and Sangath for organizing this and inviting me to speak in this. I come from a slightly different kind of organization. I belong to National Brain Research Center, which is about 40 kilometers from Delhi on Jaipur Highway. Our mandate is to understand brain function in health and disease. So we are essentially a research and teaching organization. We are also a university. And we look at the brain from various aspects as far as scientific techniques go, peering deep down, using modern tools of imaging, and looking at animal model systems using molecular biological techniques. But coming to theme of today's session, we do have a few programs that I would like to highlight today. One of them, what we call as our flagship program, which we have just kept going. This is to understand what happens to the brain in common mental disorders, for example, OCD, depression, anxiety. And we don't as such work in the field. We are not a hospital, but we collaborate with hospitals. And our idea here is to essentially peer into the brain in collaboration with AIIMS New Delhi right now and Gurgaon Civil Hospital, and try to understand what goes on inside the brain in terms of circuits that are there in various mental diseases, which are affecting people at different ages. They're not always the same, as all of you would know. And our goal here is to essentially provide tools to medical professionals to help in diagnosis and prognosis. That's one of the programs that looks at mental diseases. The second program that is more advanced is a national level program already. The flagship program which I talked about will be a national level program in the second phase, but like many other activities in various organizations, this COVID pandemic had put a stop to our ambitions. So the second program, what we call as Dementia Science Program, is to try to understand what is the prevalence and incidence of dementia in the country. As many of you would agree, until recently, we never paid attention to data in our country. We have not really worried about trying to understand how many of our people have dementia, or for that matter, any of the other disease. Now there's a lot of stress on that. We don't know how many people above the age of 60, that's what we are going to look at, have dementia. And for that, we are partnering with 4 hospitals, and we are developing 3 community cohorts in near Delhi, in Palwal, in Bangalore, which will be an urban site, and all the way in Meghalaya, which will be more of a tribal site. The hospitals include Sri Chitra, Nimhans Bangalore, as well as AIIMS New Delhi. And there is a basic biology component to that. And here our idea is to first look into the incidence and prevalence of dementia, as I said, and then try to find factors that can prevent, I would put it positively, prevent conversion of mild cognitive impairment to dementia. We know about in 4 years, about 50% of patients with MCI convert to dementia, but not all convert to dementia. And we want to understand by looking at a variety of factors, their lifestyle factor, their family background, their medical background, everything that under the sun that we could think of. We're trying to understand what actually causes certain percentage of people, including genetics, to convert to dementia while others do not convert to dementia from MCI. And we hope to come out with some recommendations in the next 3 years as to what lifestyle changes can be made to prevent this conversion. So this is our second program. Within this program, we will also have a genetics component, trying to understand if we can find some genes, but that's a long-term goal. But immediate goal, what I said was earlier. So these are the kind of activities that go on at NBRC. Other than that, we have many other research programs. Coming to the theme today, which is COVID and the brain, many speakers before me have highlighted just how pandemic is affecting mental health because of isolation, because of tension, because of fear, because of not knowing how to deal with this pandemic, how to save yourself from getting infected. We don't have enough data even today when we are almost 11 months from the first incident, which was reported in Wuhan. But there is another aspect to this COVID pandemic that I would like to highlight, and that's of our interest in NBRC for the kind of organization we are, is that we know it as a respiratory virus and it causes lack of oxygen because it affects lungs. But it has a lot of other issues with this infection. One directly related to the lack of oxygen. It leads to hypoxia in the brain. And that affects brain function in the long run. We know that hypoxia, lack of oxygen, has very serious deleterious effects on the brain functioning. The second way it affects is it causes hypercoagulation. So it can cause stroke-like symptoms in the brain by blocking blood flow. That's another problem that COVID causes. Another issue that COVID infection causes is because of very high immune reaction that body has to this infection. And because of that, it leads to a lot of problems in the brain. Most of these problems we don't even understand. One of the most common that is coming up is a variety of demyelinating diseases. And recently, in newspaper, you must have read about that how hospitals in Bombay want to understand Guillain-Barré syndrome, which is a demyelinating disease of spinal cord, which can lead to paralysis, and if it is closer to the neck, then even to death because of respiratory failure. But it's also causing demyelinating diseases in the brain, in the peripheral nerves, leading to all kinds of problems, which is kind of an autoimmune disease. Other than that, what patients have started reporting is this is about 1/3 of patients who get hospitalized. So the numbers one can work out from the total number of infection as we speak are about 9 million in India. So these patients actually have a long-term cognitive deficit, and that's we are very concerned about. Even if we get rid of spread of this contagion, this is going to create a major health problem for many years to come. The data for past 8-9 months shows that these symptoms do not go away. And if you read the description, what patients give, they forget what they just spoke about. They forget where they work. They can't familiar roads and paths where they used to walk or drive every day. They can't remember how to go to their work, how to go home. These a variety of cognitive deficits that these patients are showing up. And like I said, a study in France shows that about 1/3 of the hospitalized patients have a long-term neurological symptoms. And the back of the envelope calculation will show that COVID alone has added perhaps about 150,000 extra patients with mental diseases within India. So this is something that we want to address at a variety of levels by partnering with hospitals where they have already creating databases of patients with different level of effects due to COVID, and they are following up patients who have recovered from serious illnesses, and we'll partner with them. We will understand what are the underlying causes in the brain, and if there's any kind of intervention that can help this patient, which might be different from the traditional way we deal with these kind of problems. So this is, I can see Dr. Bhan is telling me that 5 minutes are getting over, so I'll just stop here, but I would stop with something which I think is very appropriate in this forum, that in dementia science program, which is a community-based program to understand a variety of things, as I pointed out, in the long run, we would like to have partners in our neighbor countries who would be interested in finding out these issues within their populations, because we have developed a battery of tests which are standardized tests. All 7 sites will follow exactly the same protocol so that the results can be compared across the sites, across the patients, across the investigators and volunteers, and we would have glad to share these protocols with whoever wants. We are planning to publish them, and we love to partner with our neighboring countries in South Asia if they get interested in the long run to get a comprehensive view of dementia, and later on as we progress in our other study on common mental disorders. And I'll end there. Thank you very much again, Dr. Bhan, for having me here.
Thank you so much, Professor Jain, for speaking about all of the very interesting work which is happening at NBRC and also some of the biological aspects of the kind of impacts we are seeing due to COVID-19 on the brain and the kind of research questions it's throwing up. Very interesting indeed. Susan, I just want to loop back to you and see if you are able to speak now, if we can try so that we can get your perspectives, please. So we can still see you, but I'm not able to hear you, Susan. Maybe it's an issue with the microphone. Can you try speaking and seeing if it works, because we cannot hear you yet.
You hear me now?
Yes, we can hear you, Susan. Please go ahead.
Sorry about that. That was good about technology, Seva, and unfortunately. So thank you, Anand. As you all know, Seva works with informal workers and informal women workers. To speak about informal women workers. The health of informal workers have always been a matter of concern, and we have been working with them, particularly women, and we know the issues they face on a day-to-day basis. What we have seen over the years is that the health services do not reach them and they do not reach the services. So there's a huge gap. There's always a gap. And for the most part, this gap is because of the lack of information. They do not have enough adequate information about the services. They do not have information about the health problems they are facing. So we spend a lot of time trying to educate them, trying to create awareness about different issues. Now, when COVID came, the problem was the same, and COVID was new to all of us, and we can imagine what the condition of informal workers, the poor women, what was their condition. They were locked down, they were in their homes, they didn't know, they had no clue what COVID really meant. None of us either knew. We desperately wanted to reach them because we didn't know how to reach them. But initial stages, we were trying to work out a plan how to reach them, and with the support of WHO, we developed a program where we could reach them through the phones. A phone-based intervention was developed, and we also trained community leaders. So Seva always works through community leaders, through informal workers who became leaders and who become the face of Seva in every community. So we started developing community leaders, trained them, and during the months of March and April, we reached out to several women across the country, across different states. And while we were interacting with them through the phones, many issues started emerging. And we realized that, there were so many issues around because of loss of employment, loss of wages, the schools were closed, the children were home, daycare centers were closed, small children were home, the nutrition levels were going down because children were not getting the midday meals or the nutrition at the daycare centers, and the burden of care had enhanced so much, and the women were struggling. They didn't know how to handle this. Domestic violence was another issue that they were facing. Issues around their own health, sexual and reproductive health, issues around sexual and reproductive health, addiction, alcoholism, all these issues were, we could see that they were struggling. And they started sharing this with the women through the phone calls. That's when we realized the learning from this entire program that we had, where we trained about 800 women across 11 states, and we reached out to 300,000 women and their families during the last few months. We learned that there is a need for someone to talk to these women. There are issues that these women face. mental health was not new to the informal sector or informal women, but mental health issues increased during this period because of all these multiple things that were affecting their lives. So there is a need for someone around them, someone they could speak to. And we realized that phones, it's not difficult. We can reach women. There is a possibility of having an online intervention, online ways of reaching women. And women can learn. It's not that they cannot learn. And this was very effective. So that was the learning from this entire episode that we had, the entire intervention that we had. But yes, there were challenges, several challenges. Now, these women, that the community leaders that we're talking about, or the frontline health workers of SEWA, they were not trained for counseling. Counseling needs some additional training. So we learned and realized that if we have to address mental health issues, our women have to be trained to do some kind of basic counseling. So that's the challenge. So that was necessary. And we also noticed the digital divide. Android phones and smartphones were only with men. Women did not have it. Women did not know how to use it. So there's a need for digital literacy. That was also a gap that we realized was happening. Also, the stigma around it. Women needed their space, their own space. They needed to talk to someone. They need privacy. They needed to, needed somebody around their neighborhoods, a friend who they could talk to. So these were some of the challenges we saw. And finally, after a lot of discussions with Sangath and other mental health professionals, we realized the need to develop a counseling program for informal workers, women in the country. And today we are going to, in the next few months, we're going to develop a program with Sangath and others, and we are planning to train these women on basic counseling, and we're also trying to help them to also identify, cases that needs to be further, referred for further secondary and tertiary care, and build a network of counselors and mental health professionals who could support these women and develop online counseling platforms. So this is something that we are going to work around because we know that we can do this. We've already experimented with that in the last few months. And finally, I would like to conclude here by saying that there is a need for increased investment in frontline workers. The health budget should go up, and we should have more and more health workers and frontline workers who are trained on counseling and other health issues, who can reach out to the women of our country, who can reach out to the adolescents of our country, and all these issues can be addressed. Thank you very much, Anand. I tried to cut short a little bit.
Thank you so much, Susan, also for very quickly, but I think in quite detail, talking about some of the issues as they impact communities, and the fact that communities are resilient, but they also need support, and they need us to work with them through community frontline workers and being able to launch a response which is effective and is accessible to them. Now, unfortunately, we have run out of time. It sometimes happens when you have these packed schedules. But I think we had a very impactful and very, very insightful discussion from all of our panelists. And I think there is a lot of food for thought in terms of one, understanding the challenges, understanding some of the kind of work which has happened across the region, as well as some future insights around both mental health, community-based work, advocacy, the need for policies, more funding, as well as involvement of service users in the way we launch our response. And hopefully all of these insights will be available for all of us, certainly through this webinar recording, but also will be communicated to policymakers as well as organizations working in the sector. Now, in the interest of time, I will now request Professor James to kindly deliver the vote of thanks on behalf of both RIS and Sangath. Professor James is the president of NIPO, which is a non-profit intellectual property foundation, as well as a visiting fellow at RIS, and he guides the research in health policy and pharmaceuticals at RIS. He's also a member secretary for the Forum on Indian Traditional Medicine set up by Ministry of Ayush at RIS, and works on contributing to pragmatic policy making in the area of traditional medicine. Over to you, Professor James, for the last words on this webinar.
Thank you, Dr. Anand. Are you getting me, please?
Yes, we can hear you. Please go ahead, Professor James.
Good afternoon, friends. I have the responsibility of proposing vote of thanks to the resource persons and the participants of this webinar on COVID-19 and mental health response in South Asia, opportunities for learning and cooperation. We have had a very impactful webinar on a topic that is currently engaging the attention of policymakers in healthcare. The last time perhaps we had such an effect on mental health by a particular disease was, if I remember rightly, during the early years of HIV/AIDS. That, however, affected mostly the afflicted persons and their families. But the COVID-19 effect has been on all population, both infected and healthy. This has been, to some extent, as many speakers pointed out, because of the various preventive measures resulting in job loss, compulsion to work from home, and also study from home, then the lack of social mobility, which are not issues within the healthcare programs. This also partly owing to the fear of catching the disease without warning, and almost certainly about passing the same to the dear and near ones. The serious impact of the disease on those with comorbidities, apart from the high morbidity at the early stages of the spread of the disease, is also a factor. The eminent inaugural and keynote speakers and the erudite panelists have presented the issues cogently and suggested ways to move forward. Dr. Reddy, in his inaugural address, captured the various facets of the problem, the need for health system and social system responses, and also mobilizing community resources. He also mentioned about the need for implementation and operational research, as well as sharing of experiences and expertise, especially network among the South Asian countries, which is what this webinar is beginning with. Professor Vikram Patel spoke about the unmet needs of mental health care, which is a very large area. And also he mentioned the various barriers, both on the supply side as well as demand side. He also presented some experiences, both in care and education. Some of the important observations made by the panelists are the following. There was unique perspectives based on their experience, and also the best practices and some ways forward. What has come out from the discussion in the panel is that mental health has not been a priority in healthcare budgeting in South Asia, across the countries. We have listened to experiences from situations of conflict. We also heard perspectives based on personal experience. We also had some experience from the researchers' angle, especially about the need for generating reliable data. There were some presentation talking about the biological impact on the brain of mental disorder. And there is what comes out is there's a definite need to fight against the stigma society wrongly attached to the mental health disorders and the patients who suffer from them. The use of technologies like digital technology definitely can go a long way, along with capacity and enhancement across the countries. Many mentioned about the need for psychosocial care and support, and also about integrated wellness-based response to the issue at all. Use of yoga for mental health was stressed, and at least one panelist mentioned about integrated medicine as the future. Dr. Susan Butt mentioned about the need for reaching to groups like women or vulnerable, and particular importance is to reduce the digital divide, as well as need for training and education in counseling. And yes, it is almost everyone felt that there is need for increase in the budgetary support for this mental health programs. Altogether, it was a great experience to be part of this webinar. As Dr. Bhan said, there was a lot of food for thought, and we hope to come out with a report for the policymakers on this issue. I especially thank Professor K. Srinath Reddy, President, Public Health Foundation, who delivered the very exciting inaugural address. Professor Vikram Patel of the Department of Global Health and Social Medicine, Harvard Medical School, who presented a very erudite keynote speech. Also, Professor Sachin Chaturvedi, who in his welcome address drew attention to the economic importance of the subject, and the eminent panelists, Dr. Rohullah Amin from Kabul, Mr. Mohammad Kamsuruman from Dhaka, Professor Pushpa Prasad Jaiswal from Nepal, Dr. Sunimali Madhurwala from Colombo, Professor Surinder Jaiswal from Mumbai, Dr. Ishwar Vasava Reddy, the director of the Morarji Desai National Institute, Professor Neeraj Jain from the National Brain Research Center, Ms. Shubhadra Prakash, director in Niti Aayog, and Dr. Susan Thomas, coordinator, Seva from Ahmedabad. They provided us with perceptions from different angles and also with rich and varied experiences. I also thank Dr. Anant Bhan, my old friend, for excellently moderating this session. I also thank the participants from different parts of the world who were listening to the discussions intensely but could not raise questions, and they can reach to us later. We, both Sangath and RIS, hope to publish the report as I already mentioned. I will fail in my duties if I do not thank my colleague, Dr. Namrata Patak, Dr. Ravi Srinivas, and Mr. Apur Bhatnagar for conceiving and organizing this webinar, along with Dr. Anand Bhan and his colleagues from Sangath Indore. I also express my great thanks to my colleagues in RIS, especially the internet team with Ms. Sushma Bhatt, Mr. Soumya Rangan, and others. Thank you all once again, and thank you, Dr. Bhan, for a special visit. Thank you.
Thank you, everyone. Please take care.